Hello, my name is Kelly Tebow, and I'm with the New Jersey Center for Tourette Syndrome and Associated Disorders, and I will be your organizer for this evening and would like to welcome you to our webinar on developmental considerations for OCD in kids, teens, and adults. Thank you all for joining us. Before I have my colleague introduce the speaker for tonight, I'm going to cover some housekeeping items with you. All participants are muted. If you have a question, please type it in the bottom of your question box and click send. You may send the questions during the webinar. However, we will have Dr. Gola answer the questions at the end of her presentation. We will get to as many queries as time allows. In addition, tonight's presenter is available to take questions on the Wednesday webinar blog, which is accessed from our homepage under the heading Programs. This blog will be monitored for the next 7 days. Feel free to look and post questions as often as you like. Answers will be archived for future reference. If you missed part of the presentation or would like to watch it again, an archived version will be posted to our website shortly. We value your input, and in order to expand the webinar experience in the future, we need everyone to fill out the survey when you exit the webinar. The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now, I'm going to turn over the introduction of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Kelly, thank you. Good evening and a warm welcome to everyone. I want to take a moment on behalf of the NJCTS family and to extend a special thank you to all of you for attending tonight's webinar. These are unique times we're experiencing. All of us at NJCTS appreciate all of you and extend our best wishes for good health to you, your family, and friends during this health emergency. At present, NJCTS has upcoming events that we will continue to promote. We're hopeful that we'll be able to go forward with these events, but cannot say for certain at this time. We're planning as though we will be able to move ahead, and we will stay in touch with the TS community regarding the situation. Now, with that caveat, and before I introduce tonight's presenter, I'd like to call your attention to a couple of items that we do not expect to be affected by the current crisis. Applications for scholarships for graduating New Jersey high school seniors with Tourette syndrome will be accepted until April 3rd. The deadline for Educator of the Year awards is April 10th. Information on how to apply for both of the above programs is on our website. We're still taking applications for Family Retreat Weekend scheduled for June 5 through 7 at YMCA Camp Bernie in Hunterdon County, New Jersey. The early bird pricing for this weekend ends on April 3rd. Also, registration is still open for the Tim Howard Leadership Academy at Rutgers University in New Brunswick that's scheduled for August 6 through 9. Now to the introduction of tonight's presenter, Dr. Jacquelyn Gola. Dr. Gola received her undergrad degree from the University of Delaware and her Doctor of Psychology from LaSalle University in Philadelphia. In addition to treatment of children, adolescents, and adults with a wide range of psychological disorders, she also conducts psychological evaluations for pre-operative bariatric surgery candidates, as well as psychological and psychoeducational testing for children and adolescents to assess attention issues, executive functioning difficulties, learning disabilities, and other psychological disorders. She has extensive experience in evidence-based treatments for OCD, anxiety disorders, specific phobias, PTSD, and trichotillomania. She trained at the Center for the Treatment and Study of Anxiety and the Child and Adolescent OCD, Trich, and Anxiety Group at the University of Pennsylvania. Dr. Gola, welcome. We are delighted to have you this evening, and I'm pleased to turn this presentation over to you.
Thank you, Marty, for the introduction. Okay, as soon as I can get rid of this, I can get started. Thank you, everybody, for joining me today.
The orange arrow will remove that screen for you.
Thank you. Okay, my talk is going to be about the developmental considerations for OCD in kids, teens, and adults. So I'm going to jump right in. So I just started with a comic about OCD. I think this comic shows the reality of living with OCD. This girl who she illustrates how she must do everything 8 times in a row, and if she loses count or messes up, she has to start over. And if she doesn't do this, her parents will die. These intrusive thoughts repeat over and over and over. I think this comic shows not only the reality of living with OCD, but also the irrationality of OCD and how stuck a person can get getting caught up in compulsions. So we're going to start with OCD facts. Just to go through the DSM-5 criteria for OCD. A diagnosis of OCD requires the presence of obsessions, compulsions, or both. Obsessions are defined as recurrent and persistent thoughts, urges, or images that are experienced as intrusive and unwanted, and that in most individuals called marked anxiety and distress. And the individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action. Compulsions are defined as repetitive behaviors or mental acts that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. They're aimed at preventing or reducing anxiety or distress or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they're designed to neutralize or prevent, or clearly excessive. They're time-consuming, they cause clinically significant distress or impairment in social, occupation, or other important areas of functioning. They're not attributable to a substance or another medical condition, and finally, not better explained by the symptoms of another mental disorder. So here are listed some common obsessions and compulsions that we see in OCD. This list is not exhaustive, but as you can see, there's a lot of different subtypes of OCD or flavors of OCD, some people call it. Some people who have OCD might have one type of obsession, but a lot of people have many or they overlap. OCD typically latches onto what's important to the person or maybe what's important to them in that moment or in that current time. Sometimes we refer to the whack-a-mole of OCD. So, maybe OCD latches onto harm at one point in a person's life, but then at another point it can switch over and to, for instance, a taboo or sexual type of theme. So it's not uncommon that we see people with many different types of obsessions or subtypes of obsessions. So some basic facts about early onset OCD. So it affects about 1 to 2% of the population, so 1 in 2 of 100. Early onset, which is defined as before puberty, is more common in boys than those with family history of OCD or tics. It's often associated with other anxiety disorders, ADHD and tic disorders. So often we see people with comorbid disorders. The onset is typically gradual, but it can be sudden, and I'll talk about that in later slides. And the course is typically waxing and waning over the course of the disorder. So there's a high comorbidity of OCD and tic disorders, especially in children. There's definitely a genetic link. Up to 60% of Tourette syndrome sufferers have reported to have OCD symptoms, and 50% of children with OCD are reported to have tics. 15% met full criteria for Tourette syndrome. So this is a good topic to be on today's webinars. And then tic-related OCD is characterized by earlier age of onset, overrepresentation in males, and a symptomology that tends to include touching, tapping, rubbing, and concerns about symmetry and exactness. So Souteretic OCD. This name is given to a presentation that shows blended features of both OCD and Tourette syndrome. So I think it's more of a newer label, but you know, oftentimes we see children who have behaviors that can look like compulsions, but they also could look like complex motor tics, and it's difficult to distinguish between the two. So these compulsions usually involve like a just right requirement. So these children, you know, might have to do certain behaviors until they feel right to them. The emphasis is on symmetry, arrangement, touching, ordering, evening up, and all of these. Usually, you know, with tics, as some of you may know, they may be like purposeless. So they may just involve a physical feeling that they have to engage in these tics. One question that I may have to try to distinguish between the two is if there's a feared consequence or some sort of like cognitive component to it. So a lot of these children with Souteretic OCD might report that if they couldn't carry out the compulsion, it would feel like the discomfort wouldn't end, or it would feel like intolerable, like they won't be able to sort of take it, or a vague notion that like something bad is going to happen, but nothing specific. As far as treatment goes, treatment would involve a modified approach. So it would involve both ERP, but also incorporate some of the complementary techniques that has been proven to work for be effective for Tourette's. So like progressive muscle relaxation, diaphragmatic breathing, imagery, and competing responses. So teaching the child to be able to tolerate that feeling of not giving in to that compulsion. So they may just, so for example, they may be instructed to do the compulsion until it's instead of just right, doing it wrong or less number of times than what feels right. Or they might be taught a competing response, so a behavior that they can do instead of the compulsion when they have that urge that's physically incompatible with the compulsion. I'm going to talk a little bit about Pandas and Pans on this slide. So I'm going to touch on that. So some people might be familiar with these diagnoses. PANS, distinguish between the two, PANS is more of a recent diagnosis that's more, that sort of encompasses Pandas. So while Pandas is a neuropsychiatric disorder that's associated with strep infections, PANS can actually be, might not have a known trigger, or it could be due to another infectious agent or non-infectious agent, such as Lyme disease. So the hallmark of these disorders is that OCD symptoms are a result. So in Pandas, it's caused by autoimmune reaction within the brain. So the immune system attacks the basal ganglia instead of the infection. And one of the biggest symptoms that we see is like a sudden and severe onset of OCD symptoms. So that's a clue in that it could be a result of a Pandas or Pans diagnosis. So like I said, a sudden and rapid onset rather than a gradual onset of symptoms. Here's a list of other Pandas or Pans specific symptoms that come along with the OCD symptoms. I'm not going to go into treatment at this point so much, but just know that the OCD symptoms are treated with ERP in the same way. Okay, so as you can see here, this is a diagram of the obsessive compulsive cycle here. So as you can see here, the obsessions are these repetitive images or thoughts or impulses. It causes distress in the person or anxiety, even fear or shame or disgust. So the person then engages in compulsion. So the OCD makes up like rules about what the person has to do. It may not make sense, but what they have to do either in their mind or actions that they take that will give them relief. So the distress subsides temporarily. So the compulsions are negatively reinforced because of the immediate relief they bring. So either the obsessions are like nullified, or the anxiety goes down immediately. So what happens is, as you can see though, although the relief, the distress and relief subsides temporarily, every time that the obsession comes back up, the cycle continues. So it strengthens the connection between the obsessions and the compulsions. The patient may learn that compulsions or avoidance works well to get rid of the obsessions right away. However, every time that they do this, the cycle is strengthened. So I'm going to talk about that a little bit more in the next upcoming slides. So exposure and response prevention. So exposure and response prevention is the gold standard treatment for OCD. We know through extensive research that it's the most effective treatment for OCD, in addition to the SSRI medications. Exposure refers to exposure to the thoughts, images, or objects or situations. So bringing on these things that create anxiety or discomfort, and that start the obsession. So these can be in vivo, meaning doing something in person, such as like touching a toilet seat, or imaginal, such as like writing a story of the person's worst case scenario, if this is something that we can actually do in real life. Response prevention refers to resisting compulsive behavior that decrease anxiety or neutralize the obsessions once the anxiety or obsessions have been triggered. And this treatment breaks the OCD cycle and creates new learning. I'll talk about that as well. So the vicious cycle of avoidance. Like mentioned previously, this graph is another interpretation of the previous one of the cycle. This graph represents how avoidance works, or compulsions, to temporarily get rid of obsessions and relieve the person's anxiety each time. As you can see, when the anxiety peaks, when the person either avoids the situation or engages in compulsion, like I said before, it relieves the anxiety temporarily, but the anxiety stays high long term, and each time the person confronts the situation or this thought or trigger, the cycle then continues on and on and on. They don't learn any other way of coping with obsessions. And also what happens a lot of the times with people with OCD is that the compulsions expand as well. So what we know about OCD is so OCD is never satisfied. So maybe for a while the person is doing a certain set of compulsions. So maybe they have to, say some sort of good thought or like some sort of ritualistic prayer or something in their head. And that works for OCD to get rid of the thought or get their anxiety down. But a lot of the times what happens is that the rules might change. So OCD's rules may change. It's pretty tricky. And the person has to do more compulsions, or maybe have to repeat the compulsions over and over. or it will generalize to like new situations where the person may not feel the need to do compulsions before. So as you can imagine, that will get in the way, can definitely easily get in the way of the person just conducting their normal life. This graph shows the adaptive cycle of approach. So, I didn't know it actually did that. So this graph shows what happens when, or what could happen rather, when the person sits with the discomfort and does not engage in the rituals. So this is the basic tenets of ERP is to teach the person that they can, if they can break the cycle, if they can learn to either stop the compulsions, eliminate the compulsions, or reduce them, they often learn that their fears do not materialize, or that they can tolerate discomfort longer than they expected. So oftentimes, as you can see in this graph, the anxiety might reach a peak, but over repeated exposures, so doing these exposures over and over and over again across multiple days, anxiety naturally might go down, because anxiety can't stay high forever. So habituation might set in faster. So one analogy that I use to describe this is how, if we jump in a cold pool, we might want to jump out quickly because it might be really cold and we don't like it. But if we stay in the pool, the temperature of the pool doesn't change, our body just gets used to the temperature of the water. So that's how habituation might work for exposures. I'm going to contradict myself a little bit here. So I wanted to put a slide in about inhibitory learning model. So what this is, there's a lot of research in the last few years about this model, which brings in a lot of recent research about how the brain learns and remembers information related to fear. So this model actually, instead of focusing on habituation for anxiety for OCD treatment, the focus is on building the tolerance of anxiety or discomfort. So we know that habituation is a little complicated. Some people don't experience habituation during or between exposures, but still improve functioning. Some people have a good response to ERP, but might relapse later on. And some are able to habituate, but still don't improve. So we know that it's complicated. We also know that when the focus is on habituating to anxiety, that still suggests that anxiety may be bad or like dangerous, that we need to like get rid of it as fast as possible to be able to live our life, which is definitely not the goal of ERP. So we know that this isn't true. So we want to teach the person to live with their anxiety, even if habituation is natural and it's nice when that happens, but we want to teach the person that they can live their life with anxiety. So we focus more on responding to obsessions. So if the person is not engaging in their compulsions, and instead they're able to learn other strategies, then they will have better management of their OCD and be able to do the things that they want to do rather than letting OCD control them. So with the inhibitory learning model, the exposure exercises are designed to disconfirm expectations. So this aim is providing the person with new knowledge. So with exposures, with ERP, the person will learn that their fears are less likely than their OCD is telling them, or less severe than they predicted, that their anxiety and their obsessional thoughts themselves are safe and tolerable, and that the compulsive rituals are not necessary for safety or to tolerate anxiety. So for effective ERP, the goal is to help the person learn that the feared stimulus is safe. So what happens is when there's successful exposures over time and over repetitions, it actually blocks out or inhibits the existing fear. So this is where the new learning occurs. This new learning in their brain will kind of win out if it's repeated and there's enough of this disconfirming these expectations. Okay, so now I'm going to just focus on OCD in children. So although the criteria is the same in the DSM, OCD looks quite different in children, young children especially, and teens and adults. Hence why I'm focusing on that in this presentation. So there are these nuances in treatment depending on the age of the patient. So psychoeducation is like a huge component before we jump into any of the real work of the OCD. So OCD is conceptualized as a neurobehavioral problem. It's not anyone's fault. So we talk about it as an analogy like diabetes or asthma. So we want to reduce any stigma or blame for the OCD. You know, this is something that we learn how to better cope with and better treat. Sometimes I talk about OCD as like a brain glitch to kids. So your brain is just overreacting, you know, maybe the brain thinks that these things are dangerous, but it's sending out a lot of these false alarms. So there's a lot of education about OCD and anxiety and how that works with our brain and body. And there's a lot of teamwork with this treatment. So I try to talk in terms of you know, we, the team, being maybe parents, the kid, and you know, myself as a psychologist, are working together to beat their OCD bully. And this works pretty well with kids that are competitive as well. One step is to increase their awareness of OCD symptoms. So this is both for the kids and parents. So it may start with, after really getting into some of the education, we'll start with tracking OCD. So both the kids and the parents, we want to really know their OCD, like know it really well, so that way we can fight against it. I want the kids and parents to really understand the connection between obsessions and compulsions. So once we really know like all their obsessions and their compulsions, I want them to fully understand how they link together. So with kids, it's important to use age-appropriate metaphors and language. So it's going to be more concrete, more specific, and child-friendly. So some of these exercises, I like to have the child maybe name the OCD, and this helps to externalize it. So I like doing this for kids because it helps them really be able to identify what their OCD is and see it as like this bully that they're going to boss back, or sometimes with other kids we have them you know, draw their worry monster, their bully. Sometimes I like to have them draw their islands of OCD, so they might draw how they're what kind of different islands of OCD that they have, so what are their different obsessions and how that gets in the way of their life. Sometimes I like to have kids read books and videos about other kids with OCD. The Unstuck movie is a really great one. And sometimes creating books about child's OCD, especially if they really like being creative. So here are some, I'm going to go through some of these kid-friendly analogies here that I like to use within the, you know, in sessions. So one analogy I like to use a lot is talking about OCD like the dog at the dinner table. So the way this works is I talk about how their OCD is like the dog begging for food at the dinner table. So here's a picture of my dog, and he's really good at that. So if the dog's used to being fed, the dog's going to always be, begging for food whenever there's food present. And I use this to talk about how, if we suddenly stop deciding to feed the dog's not going to just go away because he's used to being fed. So he might actually up the ante a little bit and paw and maybe bark and whine and just be extra annoying because he knows that he's used to being fed. And if we really didn't want that behavior anymore, we wanted to, stop the dog from begging. We're going to be really firm and consistent and really withstand that as much as possible until finally the dog will eventually learn that he's not getting any food. Haven't done that yet with my dog because it's really difficult. But I think this analogy works really well, especially when kids have dogs and we can talk about their dog, to teach them that even if it's really tough in the beginning, because it's the first time that they're fighting back, it will get easier. And this is the same thing for the bully at the playground analogy. So it's the same concept. Weeds in the garden, I use that analogy to talk about how when we work on OCD, we have to make sure we get all of the weeds. So if you leave any, it's going to grow back, or it might grow back. So we want to make sure we don't leave anything. OCD can be really tricky. So I tell them that sometimes OCD tries to get the kid to side with them, but we want to watch out for that. And we want to be like a detective in that. I already talked about the jumping in the pool analogy. Learning an instrument or practicing a sport can be a good analogy just to talk about how important it is to really practice. So even if we're meeting once a week, this treatment involves doing their homework. So they're going to have exposure homework every day. So just like, practicing, soccer or learning the trumpet, they have to keep practicing. So they're ready for like the recital or the game day, which is like their life when this pops up. They want to have these skills. Okay. So talking more about exposure for kids. Parents are a large part of treatment. So especially for younger children, this is going to be just as much as teaching parents about the treatment as the children. I'll talk a little bit more about parents as well and a little bit later in the slides. But depending on the child's age, it might determine how much the parents are in the session. So for younger kids, they might be in for majority of the session. There might be more parent-only sessions, and the treatment. The sessions may be more time with just the children if they're a little bit older. But there's always going to be parents involved. So with kids, there's going to be a greater use of goal setting and reinforcement. So a lot of the times with children, I like to use a sticker chart for exposure work. So maybe, we might have some exposure homework and we, create a fun, a calendar chart for what they have to do over the week. And I have them come up with like a prize menu that they want to earn. So it's really important to give them incentives because this is really tough work. And they may not be internally motivated to do the work at that point. It might just be the parents really wanting them to get some help with this. So it's really important to reward them for their efforts. Sometimes I also do that in sessions when they do some really good exposure work. We set some time aside at the end, maybe to play the game. So I know that they know that they're being rewarded. Okay, so exposure should be fun and creative. The more that this can be like fun for them and sort of that they're engaged in it, I think the better that it is. So just some examples here. There's we can use Go Fish OCD, maybe Mad Libs with like taboo words, OCD harm bingo. For one kid I remember I worked with, he had a fear that that like bad luck would come to his family. So we made like a bingo card and we all played together, and we had to say some pretty scary things about what might happen to them. But it was like a really good exposure. And connecting exposures to real life fun and natural contingencies. So for example, like playing on a contaminated playground, maybe not in this right now, that might not be a good exposure right now, but otherwise, something that could be part of their everyday life, but that they can easily generalize to their life. We can also use things like apps, like a voice changer app, to say some of their obsessions out loud, or some of the thoughts that they think are scary. Okay, and a fear thermometer. That I like to use sometimes, again, not necessarily to focus on anxiety, but to help children maybe come up with their hierarchy. We use this fear thermometer, we create one maybe in the session, and they can have fun with making it. And it helps them gauge, like, how anxious do they feel in that situation? How anxious would they feel if we did one of these exposures? And it might be hard for them to gauge, but I think this is a helpful tool. Okay, and just a few points about how OCD might look different as far as the symptoms. The content of obsessions, there might be a higher rate of fear of catastrophic events or death or illness of them in themselves, for themselves or parent, or hoarding behaviors. It's important to note that younger children might lack insight about the irrationality of their actions. So they might not perceive their symptoms as unreasonable or excessive. So they might not just be there yet developmentally, and that's okay. We can still move forward with the treatment, even if that might not be present yet. Okay, I know there's a lot of information on this slide, but going back to parent responses. So it's really important for parents with kids of any age to really be important to be aware of how they might feed their child's OCD. So we know that like children will rely on their parents for getting help with relieving anxiety or avoiding their anxiety. So the parents have a pretty big role here. We know that one of probably the most common conversation is talking to parents about accommodations or participation in their children's rituals. So oftentimes the parent might have this belief that maybe it's their job to protect their children, of course, and maybe he or she can't handle this situation, and they want to comfort their child. So it's important to talk about how accommodations or participation in rituals could, what that will look like, and how that actually feeds into their child's OCD. So I'll have a conversation with parents about how they can validate their child's anxiety, but look out for and start to eliminate what would be actually, feeding right into the cycle. So examples here, like parents will reassure their child that nothing bad will happen every time that they ask, and a lot of the times it becomes repetitive. Washing or showering when the child requests this from their parent to avoid spreading contaminant. The list can go on and on, but this is definitely an important aspect. Sometimes parents might be over demanding. They might have thoughts like, this isn't frightening, they're just acting like this for attention. And this is definitely invalidating their experience of fear, and that it might push them to approach something too difficult for them. Sometimes parents might actually, it's very common for there to be two poles. So, maybe the parent might feel like they're oftentimes overprotective, and maybe they're not doing enough to promote the child's like self-sufficiency. So they might have inconsistent responding. between overprotective and overdemanding. So I took these sort of these labels from a really great parent program for anxious children. And supportive describes how parents, sort of the ideal response. So it's important to teach parents how to be validating of the child's fears, but encouraging them to withstand anxiety. So, this is scary for you, but I think you can get through it. It might be something that they, you can say. They might think, all right, it's my job to prepare him for dealing with the challenges in life. So it combines like an acceptance and like legitimizing their children's fears, but also this belief that the child has ability to withstand more anxiety than they have now, or at least a little bit more anxiety. And that kind of response really drives the child into, they will pick up on that, and they will, they will learn that, or at least believe that they can. Okay, so now I'm going to just move on to OCD and adolescents. I'm going to talk a little bit more about that and how that might differ from children. So the content of obsessions, there might be higher rates of sexual or religious obsessions in children. And, I think that makes sense because, teens may be in a period of time where this is more important to them, or this is definitely coming up as far as something that they're thinking about more or really considering more. Their insight is typically greater. They're just getting older and learning more about the world. One of my patients, who's 18 now, had OCD since he was at least 13, said that he compared his behaviors more to his peers, and it became more clear to him like what was normal and what was not. Here's just a funny meme from John Hirschfield about sexual and aggressive themes in OCD. He has a lot of good ones on his page. All right, and parent role with teens. So just like with children, like parents can also be a large part of the rituals or the targets of their obsessions. There might, with some kids, there might be battles against their parents instead of their OCD. I see that a lot more with teens or adolescents or even children that like don't want to fight against their OCD. So they are maybe protecting it. They don't have any reasons themselves to fight it. And maybe their parents are the ones to really drive the pushing the treatment and going to therapy and doing what they should be doing. In these cases, they might hide rituals. They might fight with their parents and their therapists. Maybe they might say, this is an OCD, or they might minimize it. Some of these children or adolescents, they might act like aggressively or hostile if they're asked to like refrain from the rituals. I'm mentioning here, I can go more into this, but one thing I'll talk about with parents is, in those cases, how to deal with those like inappropriate or unacceptable behaviors, like maybe those aggressive behaviors or hostile behaviors, and talking about how they may like punish those behaviors. And sometimes parents can get a little bit, they might be unsure, I don't want to punish the child's OCD, but I distinguish this from, the child may have anxiety. We're not punishing the child's anxiety or their feelings of anxiety or discomfort, but or the punishment will be about how they're responding to it. So I hope to try to work with these teens or these children how to better deal with their anxiety, how to better manage their anxiety so they're not acting out like this as much. So, like I said before, especially with older teens, it's important for parents to have the psychoeducation, to have the resources and the guidelines of what to do and what not to do, but the emphasis is on the teen owning their own treatment. So the parents can be, it's important for them to be supportive and encouraging of their teens' efforts with the ERP, Also focusing on eliminating their accommodations, any participation in rituals. And teens can also get rewards for attending therapy and doing their homework. So the rewards might look more like less chores or gift cards, food or games, money even. Again, this is really tough work. So, it's, I think it's really helpful for them to know that they can, that they can get something else for it. Okay. A little bit more about working with teens. So this is more collaborative. Like, so when I'm working with teens, I talk about how, I'm the coach. So I act as maybe a coach role. I might be an expert on OCD, but they're the expert in themselves. I can't impose the treatment on them. So they definitely don't want another adult to tell them what to do. So, I tell them that they can make a choice. This is how I expect that their OCD will go if they don't, get on board with trying to treat it now. And they can make a choice of, if they're ready or not. Sometimes I know that this is tough for parents if they're not ready. But I try to get a buy-in from them. So I try to engage them actively. So I might have conversations about like how OCD might interfere with their life, how it might affect things that matter to them now. So they're probably not going to care about, if I talk about, way into the future what their life would look like, but what does it look like now? Like, is it getting in the way of school or their friends or sports? How so? Or what would their life look like if they didn't have it or if it was better managed? So they start to consider what a life would be like without it. Like I said, it's important to tailor to their interests and their developmental stage. So I always hope to get that buy-in with them. There's also some analogies that I think could be appropriate to teenagers more so. I talked about some of these, but an analogy can be like, we're training, just like you're training your muscles, you're training your brain. For kids that like football or sports, we can, I can talk about like, we want to know what OCD is going to do next to counter it. Just like, play a football play or with a strategy game, we want to attack, we don't want to be passive and wait for OCD. We want to like know what to come next to beat it. And, I hope to have them learn that they have a degree of influence over it. So I want to try to help them increase their influence. I want to talk more about feared consequences. So maybe with teens, they're a little bit older and they can talk a little bit more with me about like what they are afraid that's going to happen if they don't engage in their rituals. I'll talk more about realistic and unrealistic risks and benefits, and a greater use of disconfirmatory evidence. So we'll talk about, if they're doing exposures, like how did that go as compared to what their OCD is telling them or what they expected. And I like this. I really like this this comic. It's, if you can't get rid of your fear, you can't get rid of your fears, but you can learn to live with them. She's having a tea party with her worry monster. All right. Lastly, I'm just going to move into just some considerations with adults. So the prognosis is best, like many things, when treated early. So if OCD is left untreated as a child, it might it could complicate life into adolescence and adulthood. So it's best when it is caught early. And we teach them a set of skills. So the skill, no matter what the their obsessions may lie, or the age, or it's always going to be the same strategy, the same treatment. So if the skills are practiced more, of course, they might be better prepared to keep dealing with it. And there's more time where they're strengthening skills and reinforcing it over time. There's some studies that suggest some factors that are linked to a greater persistence of OCD. So how severe the illness is, a need for hospitalization, early onset, and psychiatric comorbidity. And as I said before, OCD typically has a chronic course, so spanning over several decades with waxing and waning symptom severity. Adult onset OCD, or we know that OCD can occur at any age, but it generally tends to first appear between 8 and 12 and between teenagers and adulthood. So the adult onset is defined as when the onset is after puberty. This is actually equally common in males and females, associated with more depression and other anxiety disorders. And the onset of symptoms could tie to a specific trigger, such as a loved one, death of a loved one, loss of a job, birth of a child. We know that, like I said before, OCD symptoms just latch on to what's important to the person. So it could latch on to the person's, children, significant others, religion, or sexuality. Here are some examples of content. For example, like postpartum OCD, that might have links to postpartum depression. So symptoms could suddenly appear or maybe get worse after, a woman has children, and it could latch onto that. Okay, just treatment considerations for adults with OCD. Support system is important for anyone. With adults, they don't, have the same kind of built-in support system that most children do. So patients just tend to do better when they have like a healthy support system. So people in their life, friends, family, significant others, that they feel supported by, that they can talk to, and that they feel that they can, they don't have to hide their OCD. Treatment might involve eliminating accommodations and behaviors that family members might be doing that reinforce the OCD cycle. So this, parents who might be working with a significant other, they might be brought into some sessions so they can learn more about OCD and how to help their partner. And the motivation for adults are typically higher. So usually they're self-referred, or they want to get the treatment. The distress is high, or their interference is it's getting in the way of functioning. I think because of time, I'll answer some questions on these slides if needed, but I think I'm gonna go ahead and skip these couple slides. Here's another meme about uncertainty. Just going to go ahead and skip these for time for questioning. Here's a couple of books for kids I really like about OCD. These are my favorites. Books for parents. Some online resources. Okay. Apologize I didn't get through those last slides, but here's some contact information for me. I'm at the Center for Emotional Health of Greater Philadelphia. We have offices in Cherry Hill and Princeton. I work out of both of those. I specialize in working with all ages, kids, teens, adults with OCD and anxiety disorders, also body-focused repetitive behaviors, Tourette's, and obsessive compulsive spectrum disorders. Just to let everyone know, we do have free OCD support groups and BFRB support groups monthly in Cherry Hill and Princeton. So they're free, and I think the next one's actually, maybe the next two are canceled because of Corona, but they're usually well attended. Thank you everybody for listening.
All right, then I have some questions and I'm going to launch into them right away.
Sure.
I have a question from someone who is has a question about how young might someone be to get an OCD diagnosis that's not TS related. So this individual is asking the question, teaches a preschool, and sometimes they think of a child as what what she says in quotes is a rock brain. So
Mm-hmm.
they might think of a child as having having an issue when they get stuck and can't change their way out of doing something. And she's asking the question here is that, you know, could this be OCD, and is that too young? So we're talking about 3 to 4 year olds here.
Okay. That's a very good question. So if I see a child with those kinds of behaviors, maybe like very rigid, first of all, I'm going to ask a lot more questions. Of course, the child may be too young to talk about, why they're doing this or the function of their behaviors. It's probably unlikely that I would make like a clinical diagnosis of OCD for a child that young, because it might be really tough to distinguish what exactly that is. Some kids might who might later develop OCD might have very like rigid behaviors, or these kinds of kids that have difficulty with maybe transitioning. Maybe it may look like sort of perfectionism behaviors, but at that early age, I think it's tough to make the diagnosis. I think if the child's a little bit older, maybe even around we might not, like I said before, OCD is usually not, doesn't really come out as OCD until maybe a little bit later when the child's maybe 7 or 8. So I think, I might be, go ahead.
No, go ahead, you finish, I'm sorry.
So we don't actually often see kids at our practice that young. They might first be, the parent might first bring the child to their pediatrician, and it might be keeping an eye on these behaviors for a little bit of time before any any psychologist, or at least a psychologist like myself would be brought in to the picture.
Do you think in one of the slides, I mean, there was some mention of early onset of OCD, and I understand it's not this young. However, there's a family connection.
Mm-hmm.
So I mean, we've had families with kids with Tourette that had 3 children with Tourette, and by the time it got to the 3rd child, they were diagnosing this kid at 9 months old.
Okay.
So so if there was a family history of that, you might see something at a much younger age than you would expect to. Is that a correct thinking a little bit?
Yes.
That's possible. Okay.
Mm-hmm. And again, it's probably, I would imagine that it is really difficult to tell at that young age, if there are tics or the compulsions, right? We can't really, it's difficult to figure that out.
Yeah. But for a teacher with this child in the classroom, it's something that certainly would need to be kind of observed and noticed then if they had a child behaving in this fashion, that it may not just be they're being obstinate. There's the potential that something else might be going on.
Definitely.
Okay. So this question, I'm not quite sure I have it correctly, but would a reward system be appropriate to use in school? And then further, the question is, as in an IEP, or coordinate with teachers. And if you think so, could you give us some examples of that?
Sure. Typically, at least when I think, yes, the answer, it can definitely be worked into an IEP and used at school. I don't typically work with schools. When I work with families, I don't typically work with teachers unless it's really being shown mostly at school. A lot of the times, actually, it's we might see it predominantly at school or predominantly at home. But some examples, I think it's important to be consistent. So I might work with both like the parents and the teacher, so we have a clear understanding of like what is actually being, what is actually being rewarded. So, so maybe for instance, if the child's like working on something specific and the exposures have to do with school. So if the exposures are school related and the teachers know about it, maybe they can do like a check-in with the kid at the end of the, the end of the day, or there's a specific teacher that will check in with the kid and ask them, how they did with their exposure work. Especially if, like I said, if the exposures involve school. So maybe like there's, the child maybe feel contaminated when they're in school. So they're, maybe a certain child, I've heard this a few times before, a certain child is a sort of like a contaminated. So maybe they're, maybe when they're in that classroom, for instance, and they're doing exposure of like touching maybe the desk or, a book bag or something like that. The teacher could, maybe they can reward them with something that they will, a typical reward that they will give the kids, like, maybe it's like a sticker chart they have in school. I think that's a good way of, of being able to incorporate that into the classroom.
Okay, all right, good, thank you. I have a question about support for a child. And so the question has to do with how to begin. And the question is from someone who is just kind of starting out with this whole situation. And they're trying to figure out what's the best first step. And they reference, a psychologist, or is it a counselor? And again, those distinctions there to the public may be very similar. But in reality, the difference between a psychologist and a counselor is very distinct. And I wondered if you could just address that a little bit so the parent would get a better understand of who does what.
Clarify the distinction between like a counselor and a psychologist. Is that the question?
Yes.
And do you know if they're referring to like a school counselor?
No, it's not clear in that, but I don't think so. And then the parent posted something else, that this child is 10, has had a TS diagnosis since 5, and there's waxing and waning and worries and OCD and so forth. So they're trying to figure out now, since this diagnosis, so this was like 5 years ago now, that they've been trying to work this out on their own, but they feel that they need to step outside of that now and get some more professional help.
Okay. Well, if it looks like it could be OCD, I would say definitely find a psychologist or a therapist, a professional who specializes in OCD. That's really important because some people, some therapists or psychologists could say that they, that maybe they do CBT, or OCD can be listed in like a long list of other, childhood disorders. But it is important to find someone that will specialize in OCD, so maybe they can do a better job in being able. They're going to be able to make that diagnosis, and make the appropriate referrals. So I know the IOCDF, that's one of the links there, the International OCD Foundation website has a link where you can find a therapist, find someone that does specialize in OCD. So I mean, I would say that would be the first step, just so maybe that psychologist will either make a diagnosis or, rule out that diagnosis.
Okay, all right, good, thank you. Does treatment for Souteretic OCD look different than treatment for quote unquote regular OCD?
Like I mentioned in that previous slide, it looks, at least in my experiences with kids with like this Souteretic OCD, it's very similar. we're still doing exposure and response prevention. I'm still teaching, all about what OCD is and how, and how exposure and response prevention works. I help them understand like that rationale, and then I teach them how to do, how to sit with that feeling. There might just be different ways of doing it. So like I was mentioning a little bit before, so, we're still going to do exposure, but the exposure might be, we're in my office and they have to bring on that feeling of not just right. So with one teen who had this Souteretic OCD presentation, he would like every time he opened like a drawer or like sat down on the couch or opened a water bottle, these kinds of like just everyday movements, he would have to do it until it feels right. So we would just, for exposure, we would go around and he would do it wrong, or he would like leave doors open or sit in like a weird way that didn't feel right. And that was the exposure piece. With some of the homework would involve that same thing. But like I said, we incorporated different, or like I said, these complementary techniques. So there were some competing responses built in for when, sometimes kids, they need something else to do, and they're so used to doing these behaviors and they're so quick, so we will use competing responses, and then like I said, I might not use like relaxation or relaxation training with OCD, but I will use it if it's more of like this Souteretic OCD. I say those are the main
differences. Okay. How does ERP work when both the obsession and the compulsion are purely mental?
Oh, good question. So with mental compulsions, first of all, some people might not realize that there's mental compulsions. We definitely want to assess for that. But when it's just mental, it might be trickier because we're not working with like a physical compulsion, but there's a lot that we can still do. So it depends on what the mental compulsion is. So for some people, their compulsions might be like rehearsing, maybe like rehearsing something and rehearsing what happened in the past and like making sure, something didn't happen that was like inappropriate or they didn't harm the person. So I have someone who that's like a big mental compulsion for them. So they will do their, they have to think about what happened and make sure that it wasn't something bad. Some other mental compulsions could be reassurance, so like telling themselves like, oh, that didn't happen, everything was okay, like I didn't hurt that person. Sort of like that mental checking. So with those kind of compulsions, there's a lot of different strategies that can be used, and some work better for some than others. So I like to use a lot of mindfulness techniques. John Hirschfield talks a lot about, there's a really great workbook, I didn't recommend it here, but that works a lot with using mindfulness incorporation for OCD treatment. So learning how to just acknowledge maybe, okay, this is my OCD talking, but learning how to get back to the present, because your OCD is going to pull you into the past. So this might be like a healthy distraction. So the person might, recognize, their pull to engage in their mental rituals. And, we might identify what could be healthy distractions to bring them back to the present moment. They also can do things, I teach my patients how to like maybe spoil those. So maybe they use like exposure statements and say things like, maybe, going with the uncertainty, like, oh, maybe that did happen, or maybe I did hurt my child, or maybe, maybe I did, maybe I was too, aggressive. So just going with what might be the fear. So there's a lot of different things that could be done.
Okay. So here's a question regarding a 14-year-old that has TS and OCD, and he does get stuck on some things. And the mom is saying that she tries constantly to reassure him that these things won't happen, but has to keep repeating herself about that, and it's kind of an endless cycle, and she's not quite sure how to handle that beyond the reassurance. Any suggestions there?
Sure. So that's a really common compulsion. So I would suggest that well, first of all, how old is this child? I'm sorry.
14.
14. Okay. So, I'm not sure if how much he knows, the 14-year-old knows or is engaged in, any treatment, but I would want him, both the parent and him, to understand the rationale behind why the mom can't be providing the reassurance. So, I think that's important because, if she just all of a sudden stops giving it to her and said, giving the reassurance to the 14-year-old, to the son, it might, might not be, she might not be able to continue doing it in that way. So like I said, I think it's important for them to understand why, that the reassurance can't be continued. But, instead of doing that, like I would tell a parent I would give different responses to reassurance seeking. So for instance, I might tell parents, that I can only answer this once. We want to be able to work together to beat your OCD. So I'm only answering this once and I can't answer it again. I'm sorry.
Does that work?
So that's why I really strongly encourage, it might not be met with resistance, right? So I think parents could have a lot of trouble with this. So I think that's something that we have conversations about. So there are different responses, but I think the main idea is to have them understand, that they can't be part of the ritual. And, it might be like, maybe ignoring or saying like, I'm sorry, I know you're feeling really anxious right now, but I can't, I can't be a part of this. I work with, especially if the parent is part of the ritual, then it's tough. It's not easy, but it's, it has to be consistent for them to be able to fight it themselves.
Yeah, and it puts the parent really in the middle then too. I mean, it gets complicated. Yeah.
Definitely.
We've gone over here. We're going to do one more question here. Okay. So we have a TS-OCD teen. Does the therapist have to have both TS and OCD experience or expertise? And again, from our position as the Tourette organization, we would be feeling that yes, you would. The answer to that would be yes. But from your perspective, then, would you kind of talk about that a little bit?
So you said they present with both TS and OCD?
And OCD, yeah. So what kind of a therapist are you looking for in that situation?
Yeah, so I agree. I would say it would be best to look for a therapist that specializes in both. And I think, because they're so common, the comorbidity is so common, and it's it's sort of part of this whole general conceptualization. I would say that most cases the therapist would have experience with both. But yes, I think it's important, especially if both are presenting at the same time. Maybe not less, maybe less importance if, for instance, like maybe the OCD symptoms are like primary concern, and maybe the TS symptoms are maybe not popping up in that time. Like maybe it was maybe they're not currently experiencing problems with tics, and I would say maybe a little bit less important. But like I said, I think I would imagine that that OCD specialist would have experience, some sort of experience with ticks, treating ticks.
With TS, yeah.
Yeah.
I know I said last question, but there's an interesting one here that I think is relevant. So this is the last question.
Sure.
So the question is regarding ERP, and the question is via a telehealth network for a teenager of 14 years old. And the question is, do you have any experience in that, and would that work?
So you're saying doing exposures through telehealth?
Yes, the ERP, yes, via a telehealth program. I mean, in New Jersey, we're very fortunate because there's a lot of services around us, but I can imagine it's not the case. It is not the case all over. So have you had any experience with doing that?
So that's a great question and very timely. Right now, with the way that things are right now in our environment, we are doing, in our practice at least, we're doing a lot of telehealth for the time being. And, we're getting a glimpse of what it might be like in more like rural areas where people might not be able to go into the office for, for ERP therapy. Personally, I've had only a little bit of experience doing ERP over teletherapy. Of course, there's a lot of barriers. It's challenging in that obviously, we're not going to be face-to-face working together. We're going to be in different environments, but I think it's definitely doable. We still could, especially if they're on a laptop or, their phones, they can still take take me with them to wherever they're doing their exposures. So in some ways, it could be really great for people who their OCD lives at home. And maybe like I sometimes go out to, if we need to do exposures in the home, I'll go out to their homes. But maybe there's limitations there. So teletherapy can be great to be able to do exposures that way. So it's almost like I'm there. I can still get them to. I can still do all the same therapy, and we can still go through exposures. I can be there with them and instruct them.
I would think too. It depends on how motivated the kid is too to do this. So that certainly factors in. But at 14, I would think that motivation would be there.
For sure, definitely. We are finding that with telehealth. Some of the patients with ADHD might have a little bit of a harder time, but it might not be as engaging, but we're lucky to have that option.
Yes, we are. Well, thank you. I am going to wrap it up here, and that's the end of the Q&A, and I'll turn that back over to Kelly.
Thank you.
Okay.
There she is.
Thank you all for joining us on our webinar for developmental considerations for OCD in kids, teens, and adults. There is an exit survey which we need everyone attending to fill out. The webinar blog is now open and available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to our website. Our next presentation, Parenting the Anxious Child, will be presented by Dr. Marla Deibler and is scheduled for April 29th, 2020. This ends tonight's webinar. Thank you, Dr. Gola, for your presentation, and thank you, everyone, for attending. Good night.
Thank you so much.